I want to thank the organizers for giving me the opportunity to make this presentation before the National Indian Health Board Annual National Tribal Health Conference. As you can see from this first slide, the title of my presentation are the public health and scientific challenges associated with the historic COVID-19 pandemic. Let me start off with this slide, which is a cover of the Journal of the American Medical Association of an issue that contained a viewpoint that my colleagues and I wrote, which I chose the title, Coronavirus Infections More Than Just the Common Cold. And I chose that title not to be really facetious at all, but to impress upon the reader that we have had experience with coronaviruses for decades and decades and decades. This is what's called a phylogenetic tree of the coronaviruses. The red lettering are the human coronaviruses. Bats are a very important reservoir of coronaviruses, and as you'll see in a minute, they play a role in the jumping of species from an animal reservoir to a human. I want you to focus on the yellow highlighted 4 coronaviruses shown on this slide, which are those coronaviruses which account for about 15 to 30% of all the common colds that we experience repetitively, literally year after year, usually during the winter months. But then in 2002, we had our first experience with a pandemic coronavirus called SARS. And then in 2012, another pandemic coronavirus called MERS. So let's take a look at that. SARS is the severe acute respiratory syndrome, which in 2002 emerged from the Guangdong province in China. When we did the epidemiology, it was clear that it went from a bat to a civet cat to a human. Then it led to an outbreak that was truly a pandemic of about 8,000 people and close to 800 deaths. It was ultimately contained by public health measures and actually disappeared because A, it did not efficiently spread, and B, the public health measures were very successful. 10 years later, we had the Middle East respiratory syndrome, or MERS, which emerged in Saudi Arabia, likely from a bat to a camel to a human. It did not reach the extent that SARS did, but it did, in fact, continue and is continuing to smolder in the Middle East. So now we're in the present time, and we have now the third pandemic coronavirus, which was first recognized in December of 2019. And then the Chinese identified this as a new coronavirus emerging in the Wuhan district of central China. When they published the sequence on a public database, it became clear that this virus was phylogenetically close to SARS coronavirus, the original one, so the names were changed. The original was given the name SARS coronavirus 1, and as shown on this yellow highlight, the new virus is SARS coronavirus 2. The disease itself is called COVID-19, or coronavirus disease 2019. So fast forward to where we are right now, and we are in the midst, without an end in sight yet, of the worst pandemic of a respiratory virus in the last 102 years, dating back to the historic outbreak of the 1918 Spanish flu. As of just a day or so ago, there have been 36 million cases and over 1 million deaths globally. The United States has been hit the hardest of any country in the world, with 7.5 million cases and over 210,000 deaths. With regard to transmission, it's a respiratory-borne virus. This is a light refraction photograph of the respiratory droplets coming from an individual who has a typical cough that you might see with a respiratory infection. The transmission, as I mentioned, is between people in close contact. Both respiratory droplets that you saw in the previous slide, but also recent data indicating that there's a degree of aerosol transmission, which means that particles, instead of being large enough to fall to the ground immediately, hang out in the air and stay in the air anywhere from several seconds to actually minutes or more, We don't believe that that is a major form of transmission, but it almost certainly is some form of transmission. The virus is found in various bodily fluids. However, the role in transmission is unclear. And as has been reported, animals, both domestic and zoo, have been reported to be infected, but we don't think they play a major role in the epidemiology. The risk of transmission increases with the type and duration of exposure. If secondary infections are most common, either in household contexts or in congregate healthcare settings, such as nursing homes, cruise ships, prisons, meatpacking plants. There have been a number of clusters associated with social gatherings, weddings, family gatherings, church gatherings. This is a CDC slide which shows the odds ratio, namely the likelihood that you would get transmission in the following situations. Notice the circled in red of restaurants, gyms, bars, coffee shops, and as I mentioned a moment ago, church and religious gatherings, particularly indoor without masks. A very important component of this infection is the fact that about 40 to 45% of the people who are infected have no symptoms. This is particularly important since we know that a substantial proportion of transmissions occur from an asymptomatic person to someone who in fact is uninfected, as shown by this modeling study from Alison Galvani at Yale. Getting to prevention. There are 5 major ways that are simple modalities whereby we can avoid both acquisition and transmission of infection. 1 is the universal wearing of masks or other cloth face coverings, maintaining physical distances, avoiding crowds and congregate settings, doing things outdoors much more preferential than indoors, and frequent washing of hands. The clinical manifestations are very similar to what we call a flu-like syndrome early on, with fever, cough, malaise, myalgias, etc. Also, there's a peculiar loss of smell and taste preceding the onset of respiratory symptoms. As I mentioned, 40 to 45% of people have no symptoms, but those who do, interestingly, the majority, about 80%, are mild to moderate, not requiring medical intervention. About 15 to 20% of the symptoms are either severe or critical, with a case fatality rate that ranges from a few percent to up to 20 to 25% when a person requires mechanical ventilation. If you look at what the manifestations of severe or critical disease are, predominantly acute respiratory distress syndrome, as well as hyperinflammatory syndromes. But there are a number of other organ systems that are involved, and the more and more we study this disease, the more we see this degree of organ system involvement, including cardiac injury, as manifested by arrhythmias and cardiomyopathies, acute kidney injury, neurological disorders, also hypercoagulable state characterized by microthrombi in small vessels, as well as thromboembolic phenomenon leading to acute strokes, even in otherwise healthy individuals. There's a curious multisystem inflammatory syndrome in children, which is reminiscent of Kawasaki's disease. Another interesting component of this is that people who recover virologically from the virus, often, we don't know the full percentage, but it is a significant percent, at least according to the early studies, of people who have the persistence for weeks, if not months, of symptomatologies characterized by fatigue, shortness of breath, muscle aches, fever, restlessness, temperature control difficulties, and what's referred to as brain fog, or a lack of concentration ability. If you look at who has an increased risk of severe infection and illness, it is older individuals, as shown on this slide, a much more likelihood of a hospitalization per 100,000 population if you're elderly from 75 years of age or older, compared to a very low rate among children, adolescents, and young adults. In addition, people of any age with certain underlying medical conditions are at a high risk for severe disease. Those who have a strong association with an increased risk are shown on this slide. I point out particularly people with chronic obstructive pulmonary disease. Obesity is a very important factor, as well as diabetes and the other conditions shown here. Those medical conditions that may have an increased risk are shown on this slide. Again, I point out specifically conditions such as hypertension, type 1 diabetes, and chronic lung disease, as well as smoking, in addition to the other conditions shown on this slide. Another important component of this illness is the extraordinary disparity among ethnic and racial groups, with African American and Latinx not only having an increased incidence of infection itself on the basis of the jobs and the employment that they have, putting them into direct contact with people, but also the seriousness of their infection associated with the comorbidities that they have. And if you look at the rate of hospitalization per 100,000 individuals, look at the difference in the two upper bars of Hispanic, Latinx, and Blacks at 363, 367, compared to whites in the lower bar with 80 per 100,000. In addition, if you look at the race ethnicity, take a look at the Native Americans or Alaskan Natives and their death per 100,000, 63 compared to whites at 42. The longstanding systemic health and social inequities drive these disparities seen often among Native Americans, and that is discrimination, limited access to health care. Their occupations of the work they're in put them in a difficult situation to avoid infection, issues with education, income, and wealth gaps, as well as housing with multi-generations of individuals living in crowded conditions in the same home. I want to move now to therapeutics. The NIH has established a treatment guidelines panel of a variety of experts in clinical care, infectious disease, ethics, statistics, fundamental basic science, that form a group that develop a living document that's online and accessible at COVID-19 treatment guidelines.nih.gov. That's COVID-19 treatment guidelines.nih.gov. This is the document that is updated regularly with the clinical data as it appears to allow clinicians to have easy access to what is up to date. These are some of the therapeutics in the upper part. Remdesivir and dexamethasone have been shown to be effective in advanced disease, with remdesivir diminishing the time to recovery when given to hospitalized patients with lung disease, and dexamethasone, which is a common steroid given to hospitalized patients with advanced disease, such as needing a ventilator or requiring oxygen, and it significantly diminishes the 28-day mortality. In the lower part of the slide are examples of interventions that are under clinical trial, not yet proven, but are some that are showing favorable responses, including convalescent plasma, which is available on an emergency use authorization, still awaiting clinical trial data. Monoclonal antibodies, a very promising approach of natural antibodies that are passively infused to individuals, as well as a number of other therapeutic approaches. Let me close by just mentioning vaccines. We have a strategic approach to COVID-19 vaccine research and development. By that, we mean that the United States government is involved in either the development and or the facilitation of the testing of at least 6 candidates. And what we've done is we've harmonized the approach in having common types of protocols with a common data and safety monitoring board, common primary and secondary endpoints, as well as consistent immunological parameters to allow us to compare one trial with the other. This is a list of the 3 types of platforms that are used: nucleic acids, such as messenger RNA; viral vector, such as chimp adenovirus, human adenovirus, and VSV; and the commonly and traditionally used protein subunits with adjuvants. Note on the right-hand part of the slide that 5 of these are already in clinical trial. 2 started in July 27th, and we fully expect that by the time we get to the end of this year, November and December, we'll know if we have a safe and effective vaccine. And I'm cautiously optimistic that we will have a safe and effective vaccine. The reason I say that is that we actually have promising data from a phase 1 trial. When that occurs, we're already making doses of vaccine, and they should be available in small doses early in November and December, and then in hundreds of millions as we get into the beginning, middle, and end of 2021. It is extremely important that American Indians, Native Americans, and Alaskan Natives and other minorities get vaccinated because of the increased risk that you all have for deleterious consequences of infection. I'd like to close by bringing to your attention this website, coronaviruspreventionnetwork.org. If you dial into this or link into this, you will see the range of trials that are available. And we would hope that if you have interest, you can express your interest without obligation by signing on that you might be interested in participating in one or more of these trials. Once again, I want to thank you for giving me the opportunity to make this presentation.